Hello everybody, my name is James Pipe, one of the teaching fellows at the Royal Free in Acute Medicine. Welcome to case number 3 of PFP week. This is about the Wheezy patient. So as a reminder, you can pause the video as you need to, especially when answering the questions. By the end of this session, you should be able to list important investigations and interpret results when dealing with a Wheezy patient, compare different oxygen delivery methods, recall the steps in managing the Wheezy patient, and prescribe appropriate medications. So, you are all welcome back to see Mr. Bernard Sutton. You will have already discussed Mr. Sutton in your primary care session. He's a 67-year-old male seen by his GP with a 6-week history of shortness of breath and green sputum production. He has a smoking history of 15 cigarettes per day for 40 years. He is known to have breathing trouble, wheezing, and there is no history of atopy, and he's been referred by his GP to the on-call medical team. So, on ABCDE assessment, he is unable to talk in full sentences. His respiratory rate is 28. His oxygen saturations are 87% on room air. There is diffuse wheeze throughout both lung fields. His blood pressure is 119/56, heart rate 100, his JVP is seen. He has a temperature of 37.7, moving all 4 limbs and alert. His abdomen is soft and non-tender with no leg swelling. So the first question is, which is the single most useful investigation you should do next? A, an arterial blood gas, B, blood cultures, C, chest x-ray, D, oxygen saturations, and E, blood tests. Pause now while you think of the answer before moving on. So the answer is ABG. Now, you could argue for all of these, and in fact, in a lot of occasions, the patient would have all of these things done, but ABG is the most discriminating in determining about how poorly your patient is and the likely need for non-invasive ventilation, and whether this is acute or chronic problem, and whether they are hypercapnic and or hypoxic. Blood cultures would be useful if the patient showed signs of sepsis, which we've already discussed. Chest x-ray, of course, will be mandatory. Oxygen saturations will be useful, but remember that breathlessness and oxygen saturations does not necessarily correlate. You can have normal oxygen saturations but feel very breathless, such as in anxiety. And blood tests, so you would do your standard biochemistry profile, CRP, and so on. So this is Mr. Sutton's ABG on room air: pH 7.38, CO2 7.2, PO2 5.46, bicarbonate 31.7, basic SES plus 5.3, and SATs of 87. So the next question is, what does this ABG show? A, compensated metabolic acidosis, B, compensated metabolic alkalosis, C, compensated respiratory acidosis, D, compensated respiratory alkalosis, and E, normal. Pause the video until you have your answer. And the answer is C, compensated respiratory acidosis. If blood gases need a bit of brushing up, I've prepared a seminar talk for later on in the week for arterial blood gases, where we'll go through some of these things in a bit more detail, so don't worry. Here is a table of the various acid-base disorders and what you might expect. I think it'd be fair to say that primarily the things that you will see are compensated respiratory acidosis, acute respiratory acidosis, and metabolic acidoses, rather than alkaloses on the whole are relatively rare clinically. Next question for you: what is the ideal target oxygen saturations for this patient? A, 88 to 92, B, 100%, C, greater than 95, D, 85 to 94, E, no ideal but titrate to patient symptoms. Pause here until you have the answer. The answer is A, 88 to 92. So he had an elevated bicarbonate, suggesting he has chronic respiratory failure or compensated respiratory acidosis. Therefore, he is a type of patient that is likely to be oxygen sensitive. Therefore, we would titrate his SATs to 88 to 92. B is unlikely in anybody, as we are not that efficient to run at 100% saturations. That's why it is rarely, if ever, seen. Greater than 95%, so that might be for most patients, but not in this case. 85 to 94 is too wide a range. Certainly if you had 94% SATs in someone who was oxygen sensitive, then indeed you could tip them into hypercapnic respiratory failure. And E, there is no ideal but titrate to patient symptoms. Again, that's not useful or appropriate, as remember, patient symptoms and their actual oxygen concentration are often two different things altogether. Next question, which method of oxygen delivery is the most appropriate? A, humidified oxygen, B, Venturi mask, C, nasal cannula, D, Hudson face mask, or E, CPAP or continuous positive airway pressure. Pause until you have the answer. And the answer is B, Venturi mask. So I just want to go through some of those before moving on to the next slide. So humidified oxygen actually is quite important to anyone who's having more than a few hours of oxygen, particularly if they're on a face mask. Remember, oxygen can be very drying. Nasal cannula are only suitable in patients who are well and stable and are not likely to deteriorate. Hudson face masks we'll come on to shortly. CPAP or continuous positive airway pressure is primarily indicated for those who have type 1 respiratory failure, such as through pneumonia or pulmonary edema. So for example, if you're following the latest COVID developments, you'll know that actually CPAP has almost been shown to be better than intubation and ventilation as initially thought when dealing with a COVID outbreak. So oxygen delivery devices. So you can have nasal cannula, or otherwise known as nasal specs. They can be used at a low flow rate between 1 and 4 litres. Now, it says that they deliver between 24 to 30% oxygen. Now, that depends a lot on whether the patient is a mouth breather, a nose breather, and their respiratory rate. So actually, what you can't say is that 2 litres via nasal specs is the same as 24% oxygen. They are usually well tolerated. Patients like them because they can still talk and still eat and so on, but these are for patients who are stable, have no minimal or no respiratory distress or oxygenation problem. So simple face masks, so these have a moderate flow rate between 5 to 10. Again, they deliver 30 to 40% oxygen, but again, this is approximate, and this is quite important if you have a patient who needs careful oxygen titration, such as in severe COPD. Their primary use is on the general wards, most commonly on the corridor after general anaesthesia into recovery, and for non-respiratory patients. And the picture on there shows a nurse who has a Hudson mask on. So Venturi masks have a fixed flow, and their oxygen can be set more accurately at 24%, 28, 35, 40 and 60, and their primary use is patients where exact FiO2 is beneficial, e.g. COPD, with the patient who has a potential to retain. So it might be that someone's oxygen prescription would be 24% Venturi mask throughout. It can also be a good idea to see about if you're gone from a patient who's on requiring 24% oxygen to 60 over a few hours. Knowing how much oxygen they were on before and what they're escalating to is a really good idea to tell you how quickly a patient is deteriorating. So Venturi masks certainly would be my preference. Unfortunately, we don't use them, I think, as often as we should. So non-rebreathe masks have a high flow delivery system. Their flow rate is at 15 litres, delivering roughly between 85 and 90. And basically any acutely unwell patient who's spontaneously breathing who requires the highest oxygen flow available. So a bit of extra resources for you. There is a short acute medicine shorts tutorial on my YouTube channel. You can see the link there. There's also guidelines of the British Thoracic Society and NICE on COPD and oxygen in emergencies. So other than oxygen, what other immediate treatment would you give? A, IV magnesium, B, IV hydrocortisone, C, saline nebulizers, D, non-invasive ventilation, E, salbutamol, ipratropium, bromide nebulizers. Pause here until you have the answer. And the answer is C, salbutamol and ipratropium bromide nebulizers. Ipratropium is also known as Atrovent. So the role of IV magnesium in COPD is unclear. It has a primary role in asthma rather than COPD. The important distinction to remember is that asthma has reversibility of the airways. COPD does not. Therefore, it is unlikely that magnesium would be of any benefit to someone who has COPD, and therefore is not routinely used. IV hydrocortisone. If the patient can take tablets, then there is no immediate benefit of giving IV hydrocortisone over oral. Standard dose for COPD being 30 milligrams and 40 for asthma, or 200 milligrams of hydrocortisone IV. Saline nebulizers can be useful for patients who have thick secretions, and so they're to sort of loosen up the secretion so that they can clear their chest better. Now, non-invasive ventilation would be indicated if Mr. Sutton stays in type 2 respiratory failure despite an hour or so of maximal medical therapy, which of course would include the nebulizers and steroids and so on, and controlled oxygen therapy. So these are Mr. Sutton's blood tests. He has an elevated white cell count and a mildly elevated CRP, which would put him in the probably has a infective exacerbation of COPD. So things that you're looking for within exacerbations of COPD, certainly infective, would be change in sputum or increasing in sputum production, change in colour, say from white to green, increasing shortness of breath, and increasing wheeze. Generally speaking, I have a sort of rule of thumb with CRP is that if the CRP is sort of between 10 and 50, it's likely to be an exacerbation of COPD, which is infective. If it's around sort of 75 to 100 and above, these patients probably have a pneumonic process. That's not a particularly hard and fast rule, but it just gives you a rough idea about the type of antibiotic intervention that's likely to be needed for your patient. Okay, so pause the slide here and assess this patient's chest x-ray and to see if there are any major abnormalities on it or none at all. Which single most likely pathology do you see on this chest x-ray? Is it A, focal consolidation, B, simple pneumothorax, C, rib fractures, D, hyperinflated lungs, or E, pulmonary edema? Pause until you have the answer. And the answer is hyperinflated lungs. There is no evidence of consolidation, pneumothorax, fractures, or pulmonary edema. What further treatments does this patient require? Aminophylline infusion, B, non-invasive ventilation, C, Tamiflu and prednisolone, D, amoxicillin and prednisolone, or E, IV magnesium? And the answer is amoxicillin and prednisolone, as he likely has an infective exacerbation of COPD and will require amoxicillin or doxycycline and 30 milligrams of prednisolone once a day for 5 days. Aminophylline infusion may be indicated if there was concern that he was having a severe exacerbation of COPD and was not responding to initial treatment, similarly to non-invasive ventilation. As you'll know, Tamiflu is only for flu-positive patients, and there is no role for Tamiflu in the current COVID-19 outbreak. Therefore, Tamiflu is unlikely to be used. And as I said a moment ago, magnesium is primarily for asthma patients rather than COPD and is not routinely used. There are extra resources. This is the COPD guidelines, and I would suggest that you become familiar with NICE CKS, which are clinical knowledge summaries. You've got SIGN, which is the Scottish Intercollegiate Guidance Network, and of course the British Thoracic Society. So just to give you a bit of useful, particularly for students that work at the Royal Free, there are a couple of apps that can be quite useful. iResus is one, NICE BNF is another. Here at the Royal Free and the Royal National Orthopaedic Hospital in Stanmore, we have the Micro Guide, and this is where you can download and see all of the national formulary. So for example, you've got infective exacerbation of COPD here. So first line, we use amoxicillin or doxycycline if there's a beta-lactam allergy. The MicroGuide app is free and easy to download. Thank you very much for listening. That's the end of case 3. I think you've already established my email addresses. I've also done a chest x-ray tutorial on Moodle, which will also direct you to my YouTube channel under the acute medicine section. And of course, please also see the materials that have been provided by my colleagues under respiratory medicine.